Thank you so much. As they said, my name is Francine Mutesi, and I'm happy to welcome our panelists. We also have Joy Atwine from Palladium Group, and we have Natasha Mwenda from Malawi. But most importantly, we have here in the room, we have Dr. Margaret Maulana from Zimbabwe. Thank you so much for coming all the way. So, as you know, today we will discuss about healthcare quality and patient safety. Apologies. So before we go into it, I would like to introduce myself. I'm a biomedical engineer, presently working with the Rwanda Biomedical Center as the division manager of medical technology. So today we are here to listen, to discuss about what is quality improvement and patient safety. But also we will try to understand how it can be improved. We are pleased to have brilliant and knowledgeable panelists who will help us answer these questions. We have different topics, but I will leave them introduce themselves and their topics, and also tell us a bit more about these topics. Thank you. First, we would like to welcome Dr. Margaret Maulana from Zimbabwe. Please, you're most welcome. I'm supposed to come here. Oh, really? I thought I was going to sit there. Okay. So again, thank you, and welcome, Doctor. Please. Oh, okay. Thank you. Am I the only one present here? Yes. Ah, is it? Oh, okay. Okay. I don't feel like it's working. Oh, can you hear me? Not very well. Yeah, I feel like, yes, it is, but, oh, okay. Yeah, maybe I need to hold it a little bit high. No, now I'm fine. Yes. My name is Dr. Margaret Maulana. I have come to do a presentation on quality and health safety for patients. I am a practicing practitioner in Zimbabwe, and I'm also mostly in administration, administering healthcare in our group, where we have 5 hospitals, and we actually have a whole chain of healthcare facilities in our group of companies, where we have laboratories, we have radiology units, we have pharmacies, we have optometry services, we have ambulance services,
across the whole 10 provinces in Zimbabwe. And I am the head of operations in that company. So when I was asked to actually do this presentation, I just thought, let me go and share with you what I feel are the tenets of quality and health safety as we deliver healthcare to our populations. In particular, what made me come here too was the fact that that topic has gained more weight, especially during the pandemic, because you realize that there were a lot of issues surrounding the quality of care, at the same time making sure that we have adhered to the COVID-19 protocols and guidelines, not to just look after our patients and make sure that they are safe, but also our employees, and even extending that to our families. So the topic has become extremely more relevant now than probably it was before the pandemic. Hopefully the presentation is ready so that we can share and have a discussion. Can we share the presentation? I need to time myself. It's 14:45 so that I don't get carried away. So I will be done before 3. Can we share the presentation? Thank you. Like I said, I'm talking about quality and patient safety. Next slide. So I'm just going to share what I think are the issues that we really need to prioritize what it is that we think is quality and safety, and what are the facts, and then to answer the questions about if then we are talking about safety, when can we say there's been harm either to the patient or to the healthcare services providers. Next slide. I will also just share with you, during the COVID-19 pandemic in our country, because our organization is one of the largest private healthcare service providers, I was tasked to head what we call the COVID-19 Pandemic Task Force, and I'm also part of the case management committee at Ministry of Health in Zimbabwe. So I'll just share with you what we are currently doing, which we started last year when the pandemic hit us, as Premier Services Medical Investments, in terms of maintaining the quality and the safety that we thought was the best we need to do. Like we've already noted, the topic says quality is doing the right thing at the right time to the right person. It's literally as simple as that. So if then anyone then deviates from doing that, what is defined as right, either by not doing it at the right time to the right person, automatically what it means is there is no quality. Even in our social lives, we can translate that to say, if you are measuring quality, it means there has to be an action which is being done to someone at the right time and to the right person. If you don't do it to the right person, then you cannot then say you have offered quality services. And there are components that we need to at least put at the forefront. There are evidence-based practices that we need to always maintain in whatever we are doing as healthcare services providers. And already the issue of time and effective access to care. If we create access for our patients and it's not effective, then there is no quality. If we create access and it's effective but it's delayed, that is the issue to do with turnaround times, then there is no quality to talk about. If then at the end of the day we have done everything but we don't have the clinical outcomes that are expected per service based on the benchmarks, it means again there is no quality. And if that service delivery is not coordinated and managed, in particular, especially when we speak to chronic conditions and care transitions, we would have missed the opportunity of defining the quality or meeting the quality components. Next slide. Next slide. How then do we measure the timely delivery of healthcare services? There are multiple approaches that people can do to measure that. And I'm going to just speak to 4 issues, which I thought and we as an organization have targeted. You will see when we come to the end of the presentation that it is enhancing the patient experience. And from the definition, remember we said it's doing something at the right time to the right person. So you have to somehow be able to measure that experience and be able to come to an understanding with the recipient of the service so that they can share with you that experience and acknowledge that what you have delivered is what they were expecting. Improving population health. Our patients come from communities. So if at the end of the day, they are still going to carry a burden when they go back home, and there is no improvement in the health of the population, you cannot claim that the service that you would have given to that patient was of a quality nature, because if they are still going to have a burden when they go into the communities, then it means something is lacking. Reducing costs of those services. Costs have an impact to the well-being of a human being, whether they are costs for groceries or clothes, or worse still, when they are healthcare costs, because it means patients and families will probably have to sacrifice some things that they need. They will probably have to sacrifice their children going to school to make sure that they've catered for healthcare. So automatically quality will be compromised. I was yesterday when I listened to my apologies, I think the person from nursing services, where she spoke about improving provider life quality of care. If we don't look after those who are you and me, who look after patients in as far as their quality of life, then there is no way they can then translate their knowledge and skills in making sure that the patients have received quality care. And the second point is enhancing patient experience means that we are able to communicate with the doctors, nurses, and they also are able to communicate with their patients in a way that will make them be at the same level and work together within the journey of receiving and giving the service that they are supposed to be receiving. Improving responsiveness to pain management. Pain is subjective. So as healthcare service providers, if we miss the point whereby probably someone is grading their pain at a level of 5, and you think, you know how sometimes as practitioners, because we would have probably gone through the same pain, we tend to belittle a woman who comes screaming and they are not yet maybe even 5 centimeters in labor. That is very unfortunate, because if you fail to be responsive to pain management, you would have failed as a quality deliverer of healthcare services. And making sure that we have provided clear and understandable discharge and admission information, and reviewing patients who would have reported their experience from various surveys. These days, there are various surveys that can be done. And not being responsive to those means that we would have missed the boat. And next slide. On improving population health, there is a need for healthcare service providers to implement evidence-based practice and have some level of core measures of compliance and reducing in-hospital admissions. There are some practitioners who probably, I'm not sure whether it's a practice that we have noted in our own country, but if you do a procedure on a patient and they are readmitted for the same procedure or a complication, it means there was no quality in the first place, because the stress is not just financially but emotionally and physically on that particular patient would have been missed in the first opportunity. And the hallmark of this is also reduction in errors and related complications. Then another aspect of improving population health is evaluating outcomes that measure the cost of care delivery and level of care provided. For example, stroke patients, septic patients, maternal patients, like I've already mentioned. Next slide. Like I said, reducing costs. I've already gone through this to say by reducing admission expenses, reduction in spending of worker compensation claims, employee injuries, will mitigate against patients failing to access healthcare services. Next slide. Improving provider work life. This is through preventing and identifying provider staff burnout and standardizing workflows which result in employee satisfaction, so that at the end of the day, they can also then translate that to the patients whom they will be looking after. Next slide. In terms of safety, has been defined by World Health Organization as the prevention of errors and adverse effects to patients associated with healthcare. And this is a discipline that emerged with evolving complexities because, like we have already spoken about, issues to do with reduced injuries at workplaces, reduced readmissions of patients when they are coming back for the second time, and also making sure that we have implemented patient safety strategies with clear policies and leadership capacities that drive that safety, those safety improvements is what then defines whether patients are safe in an environment or not. Next slide. And the effects that can be used are in medical, I think medical terminology is one of the best things that I've taken as a we take home message after I qualified was do no harm. It is the hallmark of patient safety. In everything that we do, whether we are scientists like my friends here, nurses, doctors, every morning you go to work, if you carry that to say you are not supposed to do any harm to a patient, implied or applied, automatically it means you have put the patients in a safe environment. Next slide. Like I said, we took an approach during the COVID pandemic and we came up with a quality and patient safety policy, which we called QualiSed. And like I was saying, it involves a lot of things. And we then came up with pillars so that everyone, including those from the back office, can contribute to operations actually delivering quality healthcare and patient safety. And this way, even how facilities are configured, how supply chain issues are done, they have to make sure that, in as far as supply chain management is concerned, the type of equipment that we buy that is used by operatives, even the type of IPC issues that we bought or we buy in an institution, the type of bandages we use, and again, like I said, putting employees in all this equation through empowering them, making sure that their activities are structured in a way that the approach is targeted at quality and patient safety. Even ICT technologies, we realize that in this digital economy, you cannot have a system that is divorced from the bedside, because at the end of the day, the services you will be giving to that patient will then not be of a quality nature, because there's a human longing and appreciation when patients are interacting with those who are looking after them. Next. In our pillars, I'm just going to zero down on the quality of care pillar, where we said when we are introducing new products and services in our organization, we're doing market extension, we are opening new units, when we are engaging specialists, we are targeting the issue of saying, are all these activities, including ISO certification, are they in line with making sure that the quality of care to our patients is that which is expected based on the definition? Next slide. Why does harm occur? Harm occurs when all this that I've just mentioned has not happened. Thank you.
Thank you so much, Dr. Maulana. I think you've touched to the heart of this discussion. Why does harm occur when there are measures, standards being put in place for the benefit of the patients? Before we go to Q&As, I would like to invite our second panelist to present. She is called Natasha Mwenda from Malawi. She's online. If our colleagues can give her the opportunity to present. Thank you. You're most welcome, Natasha.
Thank you very much. May you please confirm that you can hear me, or I'm audible enough?
Yes, we can hear you. We can hear and see you. Please go ahead.
Okay, thank you so much. I am Natasha Mwenda. I work with the Water Aid in Malawi, and I manage our WASH in Healthcare Facilities program. I have worked closely with the Ministry of Health, especially the Quality Management Directorate, as well as the Preventive Health Directorate. So I have much experience on delivering WASH interventions in healthcare facilities, and also familiar with some of the issues that we are experiencing with regards to quality of care and how that is linked to inadequate wash or whether it is linked to improved wash services. So I will talk about the essential wash for safe, quality and dignified care. Thank you. May I have the presentation, please?
Can we have the presentation on, please? Oh, thank you.
Okay, so we had submitted an abstract, but I had repackaged it in form of a PowerPoint presentation, but I think maybe that wasn't shared.
I think if you have it, maybe you can be given permission to present it, to share it.
Okay, I can share my screen.
Yes, please. Thank you.
Okay. Are you able to see my screen now?
Yes, we do. Thank you. Please
Okay,
go ahead.
thank you. Yeah, so I guess the previous presenter has defined quality of care in detail, but I'll still more run through also another definition that we have been using. So quality of health care can be defined in many ways, but there is a growing acknowledgement that quality health services should be effective, meaning that they provide evidence-based healthcare services to those who need them. They are safe, avoiding harm to people for whom the care is intended, and also people-centered. That means providing the care that responds to preferences, needs, and values. And how does WASH come into play? So when you have a clean and safe healthcare facility, it increases trust and the demand for services. It also improves the experience of care and strengthening even staff morale and performance, as well as reinforcing the role of staff in setting society hygiene norms. And then also we know that if you have adequate WASH services, they also strengthen the resilience of health systems to prevent disease outbreaks, allow effective response to emergencies, including natural disasters and outbreaks, and bringing emergencies under control when they occur. I think this has been very evident now that we have this COVID-19 pandemic. Most of our health systems have been put to test. However, if we don't have adequate or poor WASH services, they really have a negative impact on the quality of care. We see increased risk of exposure to hospital-acquired infections for both patients and healthcare workers, injuries happening even in the healthcare facilities. In other instances, risk of abuse, mainly for female patients. And then these all lead to loss of trust in the health systems because other practices are conflicting with the social norms and the traditional beliefs or cultural beliefs. And then also we are issues of loss of dignity for patients and even healthcare workers, because when you don't have the proper wash infrastructure, patient privacy is affected, because now maybe patients are driven to do open defecation, and we have some psychological and emotional trauma that comes with those experiences. And even others, they are denied access to healthcare because of maybe some practices that happen when people go to access the healthcare services. And we also know that this also affects our healthcare workers, because they're exposed to working environments that are degrading. So that is the impact of WASH. And I'll give an example of what happened in Malawi. In 2018, there were newspaper articles being printed on how one of the major health facilities was removing uteruses for women who had cesarean sections at an alarming rate. And this drove the Office of Ombudsman to do an investigation. And among the findings, I think some of the findings were that the major cause of the uteruses being removed were infections, because the wounds they were infected. And when they dig deeper, they found that in most of the facilities, they have insufficient ward space, beds and theaters, as well as compromised sanitation, which now increased the number of maternal infections and the attendant uterus ruptures in some instances. And then they also noted that in most of the facilities, they had a lot of water leakages, which affected the water pressure, meaning that the hospital did not have adequate water to be using for cleaning purposes. So those were some of the findings. But all these would have been avoided if the WASH services were prioritized by the hospital managers. And we know that for safety to take place, the WASH is key. And as you can see, we have a lot of non-functional WASH facilities in points of care, and these even include the poor disposal of medical waste, which now becomes a hazard to the patients or even the healthcare workers and even the surrounding communities. And for instance, when you have a hand washing facilities that is not functional, chances are very high that that will also be a neglected area when it comes to cleaning. And then it becomes now a surface where pathogens now start to breed. So these are things that we overlook, but they have a great impact on the safety of our patients and even our healthcare workers. And also, you look at the conditions in which some of the healthcare workers are exposed to, working without PPE, which means that they are at higher risk of being infected by infections, as well as transferring the infections to patients. So patient safety and the health worker safety is still being compromised. And even where we are having challenges of water supply, and we have our maybe patients being forced even to walk long distances to fetch water, that compromises their health as well. Imagine an expectant woman having to go and fetch water to be used when they're at the healthcare facility. That also discourages people to access healthcare services on time. And we have even seen worse scenarios where women are exposed to degrading environments, having some bathing shelters or even toilets that are not secured, where they can be exposed. But we all know that your time in the toilet is a private time. But we expect that people should still go and access quality care in the healthcare facilities, which do not have that enabling environment for quality care. And even the way I liked it when we talked about standards, but then I have also noted that we can have standards on paper, but if they are not reinforced, then we are not solving anything. So you have some WASH infrastructure that is substandard, that is not fit for purpose, even in a healthcare facility. So which also put the users at risk, because now they cannot use the proper infrastructure that is provided, and they need to find other makeshift means to help themselves when they want some services regarding to WASH. But I think from where I sit and from the interventions that we are doing as WaterAid, we have seen that just bringing in running water makes a difference at a health facility. The health workers are motivated, they are happy, the clients are satisfied, because now they know they can do everything without any difficulties. And we should remember that if the healthcare facility doesn't have water, it means that even the healthcare worker in their households, the water is also an issue. So they have to address that issue at home first before they come to work, and that compromises the efficiency in terms of how they deliver their services. Much time is lost trying to manage the water situation at home. And we see how the improvements on infection prevention are being effected in the healthcare facilities, and also how now the management structures are empowered to hold accountable the healthcare workers if they are not following the procedures and protocols, because an enabling environment has been provided to them. And this also helps the healthcare workers to model the good hygiene behaviors that they need their community members to follow, because they're able to practice that in their presence. And we have also seen how the WASH helps to bring trust in the healthcare system, because we know that in an African setting, there are a lot of cultural beliefs, and people need to be given an assurance or a guarantee on certain things. So, like for instance, here in Malawi, you cannot just expose a placenta anyhow. But for people now to be convinced that those placentas are being disposed in the right way and no one can tamper with them, you need to show that you have a secured place where those things are being exposed. And you gain now confidence even in the clients, because they feel safe. So that's what as WaterAid we are also doing and promoting, just to make sure that the people are receiving the service that they desire based on also their preferences and their needs. And we do not stop there on the infrastructure only. We have been also working closely with the Ministry of Health, raising awareness to the patients, the surrounding communities on the Hospital Ombudsman platform, which the government of Malawi introduced. This is an accountability platform where patients can provide feedback on the quality of care that they have received. This also includes the grievances that they have, maybe whether on the WASH services that are at the healthcare facility, how the healthcare workers treated them, and so on and so forth. So and ensuring dignity, we also try to give a voice to the patients so that they are able also to provide their feedback. So even the hospital ombudsman, they are now trained on how they can generate the feedback from the patients, and how they can also use that to influence improvements in the delivery of quality of care in the health facilities, and the right decision makers to be engaged in order for the improvements to be done. So this is how we are working around ensuring that WASH is being included and prioritized for the improvement of quality of care and experiences of our patients when they are accessing services. And for us, I think we still engage with government because the work that we are doing is a platform for us to influence good practices and policies. So we engage government, and for now, our call to action is around ensuring that the status of WASH in healthcare facilities is a performance issue, so that even the hospital managers and administrators, they are taken to task when WASH services are not functioning, but they are continuing to provide services in those kind of environments. We are also calling for action to increase access to quality and improved WASH in healthcare facilities, so that it is also treated as a human right, because we know that access to quality healthcare is a human right, and access to water and sanitation, they are also human rights. So no one should be denied that right, regardless of the setting in which they are in. And then we are also requesting an increase in WASH technologies that consider needs and preferences of different groups, including women, people with difficulties in mobility, and diverse culture and religious beliefs, because all these are people that require those services, and we need to consider them when we are delivering, if we are indeed to achieve quality of care, as well as strengthening the feedback mechanisms, because we cannot know where we are going wrong or right if we don't get feedback on the services that we are providing. And this also empowers our patients and our clients, and it improves the communication between the service providers and the clients. And then we are also requesting government and health managers to create safe physical environments, because these do not only affect those who have come to receive services at the healthcare facility, even surrounding communities, they can be affected if the environments are not safe. Thank you very much.
Thank you so much, Natasha. Patient safety is something that is very, very important when we take care of our patients, but it is understood from different perspectives. For example, as a biomedical engineer, if you ask me, I would start talking about electrical safety and calibration of equipment. But we have, we've got different panelists here with different views and advice to us. I would like to, before we go to the next panelists, I would like to invite questions. I want to start with one of my own, asking, in this age where we are using digitization, technology to deliver healthcare, how can we use them to improve patient care, patient experience? Maybe we will have it answered later. If we can get 5 more questions before we go to the panelists. Thank you. We have one question here. Do we have someone to help with the microphone? Yes, please.
Thank you very much for all your presentations. They were so inspiring and really educative. Mine is not a question, it is an intervention, if I can go ahead.
Please go ahead. My
name is Mudashishwa Bagambake. I'm representing an anti-drug organization in Rwanda, ADOR, but also we are in a network of men engaged Rwanda, ROMNET, with 35 local NGOs fighting against GBV but also improving and inspiring youth to live a life free from substance abuse environment. So recently, 5 months ago, I've been intervening in the area of gender equality, women empowerment projects, training those who are living with gender experience to change, to cope up with a good life among them, though their experience was so bad, and also there was most of them police case and rape case in local villages of South Province in Rwanda. So considering also the model you have been doing using called GOT, the journey of transformation, teaching them as couples to improve their health, even also in the area of body cleaning, washing, as we found that it was also among triggers of gender-based violence. So coming to this presentation, I found that what you are presenting is very, very impactful and so educative. And really, if it is possible to expand those teaching in other networks, and more especially in NGO working in the partnership with the Ministry of Gender and Family Promotion. Thank you very much.
Thank you so much, Mr. Mugambake. Your intervention is very important and timely. I think partnership between NGOs and government to improve on this will be a very good area to make efforts. Panelists maybe will also comment later after the next question. Do we have another question? Feel free to provide suggestions, inputs, questions, anything related to patient care and patient experience improvement is most welcome. Yes, please.
Yeah, thank you so much. Since yesterday, I was very much touched with what WaterAid is doing. I've ever worked in hospitals. I know what it means. Lack of clean water, and also management of waste. I know it's a source of nosocomial infections, and patients cannot get healed without, like, treating one disease and then the patient goes back with another or attracts another infection at the hospital. So it delays the time of healing, the duration, and also it becomes costly to the family, and also it has other impacts, so like mental and other related issues, because the patient takes long to heal and takes time in the hospital. But still, I think, as he just mentioned, I think it would be good also to look into bringing these services to the community, where these patients are coming from, and where the service providers are also coming from. Sometimes you find people are lacking improved latrines at home. They are lacking water for hand washing, and also facilities. And also when it goes to food, water for cleaning vegetables, fruits, and also for cooking and drinking. So you find it's also increasing these diseases that are related to poor hygiene and leading to increased number of patients, not only to vulnerable groups like pregnant mothers, elderly, under 5 years, under 5 years children, but also to the entire family and the community at large. Especially when it goes to latrines, you know how these diarrhea and other related diseases spread in the community, like cholera and others. So I think it would be great to hear about other approaches on the integration of bringing these services also to the community level, not only to the health facilities. Thank you so much.
Thank you so much. In other words, our panelists will have to touch on how do we bring safety, not only of the patients in the hospitals, but also to the communities and to our women in the communities. One more question? Maybe we can have these, the interventions answered, and then we'll continue another round after that. Thank you. You're most welcome, Dr. Maulana.
Thank you very much. I will start with your question on digitalization. But in the process, I'll also maybe make an addition to what the two speakers from the floor commented on. Digitalization, in as much as it has brought efficiency to the way we do things in a hospital setup or in a clinic setup or in a laboratory, one thing that is undeniable is it has then, if not managed well, created a vacuum of information, a vacuum whereby the recipients of healthcare services, we have to seek for answers from the digital platforms. So as healthcare service providers, we have a duty to make sure that we have relentlessly communicated, relentlessly availed information to our patients, availed information to even to the caregivers, so that when they are then, when they encounter questions or doubts from patients, they give accurate information about the status of those whom they are looking after. If we allow patients not to participate in their healthcare service delivery, and we treat them at a distance, and we don't make them partners in delivering that care, they'll go out there and seek to fill that gap. And when they then fill that gap, because usually on the digital platforms, there are no explanations. And if the explanations are there, they are not tailor-made maybe to the culture issues, to age issues, to even regional issues, to even disease issues, which might impact on the quality and safety of that particular recipient of that care. And like you have rightly said, when you look at gender-based violence and extending the issues of water and sanitation to the community, there is no point of us concentrating on patients or victims when they have come to the institutions. We have to go out there and avail information about what it is that they need to do, what is available for them to feel safe, how they can utilize their resources so that they can benefit from the water that we are talking about, that it is a medium of making sure that healthcare services are of a quality nature and they make an environment safe both for caregivers and patients, and they continue to also partner us to make sure that this scarce resource is then utilized in an efficient manner. Thank you.
Thank you so much. Natasha, do you have, are you available to provide your inputs as well?
Yes, thank you so much.
You're most welcome.
I think the question on digitalization, it's a very important one, and we cannot rule out technology because we are living in an era where technology is taking over. But then I think the most important thing is that we need to be deliberate and proactive in defining how we want technology to be used, because at times we come in with innovations because we are just trying to address the immediate problem or immediate issue, but we haven't had a chance to look at the long-term impact that those innovations or technology may have. But I've seen in Malawi where they have what they call a hospital on the phone, and this has been very helpful in following up patients maybe that are on ARVs. It has been very helpful following up on expectant mothers, reminding them on their time to come to access the antenatal clinics, and all those details being provided. And it has been very helpful, especially for those who are in hard to reach areas, that maybe they get some of the information without having to walk or go to the facility. But then we can't rule out also that there are certain things that require in-person contact, because we don't want to lose that emotional touch as service providers that we have with our communities or our clients, because some of our decisions as human beings are also compelled by the emotions that we have or the connections that we have with our patients. So we need to just strike a balance in that regard. And then in terms of bringing WASH services to communities, so as Water Aid, especially like here in Malawi, the way we work, we do not only target institutions, but we also target communities, because apart from providing the water and sanitation facilities, we also are promoting hygiene promotion. And you can't expect a person is doing something different at home and they come to the hospital to practice all the good hygiene behaviors. That cannot be possible. So we try as much as possible to do what we use, an approach that we call a district-wide approach, where you are targeting the community settings, you are targeting even the schools and even the healthcare facilities, everywhere where you know that the people can find in a setting, every setting where you know that the people can find themselves. So we try as much as possible to bring services across and in all these settings. And even the issues of digitalization. So we also use that in providing services, WASH services. So we have the M-Water platform where you can easily generate what we call the water points mapping, the sanitation maps, which shows each particular community and how the water points are distributed in that community, so that we are able to identify maybe the areas that are in need or the areas that have a high concentration of those facilities, so that we can intervene in other facilities, maybe that are not adequately serviced by the WASH services. So that's how I can respond. Thank you.
Thank you so much, Natasha. We will take 2 more questions before we close the session, if we have any. Thank you. Our panelists have been very, very explanatory, and I think that's why you don't have many questions. Maybe a last question. With COVID-19, in a COVID-19 world, what are the lessons learned in terms of patient safety and WASH practices? I would like our panelists to let us know, especially in their respective countries. In Rwanda, we've learned a lot. We have, I think in Rwanda we have managed to set up a lot of WASH solutions in hospitals, in public institutions, countrywide. There has been a lot of programs to teach the population the benefit of having washing facilities, cleaning your hands before you enter in a place. I think we can see it wherever we go. We've also seen a lot of improvement in patient safety, patient care, through improvement of services, availing medical technologies, medical equipment, medical infrastructure. So I would like to hear from our panelists how or what are the lessons learned in your countries in terms of patient safety and WASH practices, briefly. Thank you.
Thank you very much. The era of the COVID-19 pandemic was really something that came like a big bang issue. For starters, most countries, I'm not sure about Rwanda or Malawi, where Natasha comes from, we were caught flat-footed because we never see it coming to our country. So in terms of preparation, of even handling and treating and screening, we only realized when we were already hit. So ours was almost like a reactive manner of then making sure that, like I said in my presentation, you can't have or talk about patient safety without making sure the environment where they are going to be looked after is in itself safe. And the people who are going to be looking after them have complemented to that, to making that environment safe by them being safe practitioners and safe healthcare service providers. What do I mean by that? We realized that it was a partnership, like I said, whereby patients needed to know that if they were not going to disclose their contacts and disclose where they would have come from, and then they bring the virus to an institution, maybe they miss the screening point because they have not yet had symptoms. They will end up having spread the virus, not just to employees, but even to that environment and to other patients, making that environment an unsafe environment. We then also realized that most institutions needed to make sure that the caregivers are safe initially themselves, not just in the workplace, but even in the communities that they stay, by availing information about how the virus was being spread, what it is that they needed to do outside just having lockdowns, outside having restrictions like curfews, but making sure that there was a scaling up of basic things like hand hygiene, where there is no sanitizing equipment or material, to just promote that the hands that they use in a day-to-day living in their homes, and promoting that they wash their hands before they touch themselves, they touch their children when they go back home from work, and there is available water in the home. All those things, there was a drive to make sure that the basic things were shared and the basic things were availed to just make the environment, both inside institutions and outside institutions, safe. And in most instances where people adhered to the basic things, the spread of the virus was curtailed. But in instances where there was no availability of water, basic water, those areas became hotspots of the spread of the virus. Thank you.
Natasha?
Thank you very much. I think the context in Malawi is not different from Zimbabwe, and I think it's also almost the same as in Rwanda. But I wanted to say now how this COVID-19 has also maybe helped us in advancing the WASH agenda, because when it comes to healthcare services, it is easier to advocate for adequate drugs in the hospitals than it is to advocate for adequate toilets and water. But then because of COVID-19, and also here in Malawi, treatment centers, isolation centers were only in government hospitals, were only in public hospitals. So we saw even prominent people in society maybe being admitted in government hospitals where maybe the WASH situation wasn't good. And this has also helped in changing the mindset and pushing those decision makers to prioritize WASH investment for healthcare facilities. And I think one other lesson that we have learned is that because the COVID-19, it's coming in waves. So the first wave comes and it goes. So because the people are more reactive, the behavior change has not really sunk. People run to wash hands because they are afraid. But when the scare is gone, people go back to their default settings, where maybe they now become complacent on hand hygiene and so on. But I think with the continued engagement, so what we have done is that when the cases have reduced, we don't stop in our advocacy work or in our hygiene promotion work, because we still want the people we want to influence the behavior change. We just don't want to end at, okay, now the pandemic has, cases have started again and we start running. We are maintaining that same momentum that we had during the high cases, so that when another wave strikes, at least we are better prepared. Because we saw that even in healthcare facilities, we had challenges because the facilities were not prepared. So even healthcare workers were reluctant to attend to patients. And patients were also afraid to go to the healthcare facilities because the environment was not enabling. So we saw that both sides were being impacted by the pandemic because of inadequate WASH, and quality of care was seriously affected. But now I think even in the level of investment is increasing to make sure that we improve WASH in the healthcare facilities, and not just because of the COVID pandemic, but also having forward-looking kind of thinking in maybe future pandemics so that the facilities are prepared for whatever outbreak that may come out. Thank you so much.
Thank you so much. I am told that our other panelists were not able to join us online, so we will end our session here. I just want to thank our panelists. I think flat-footed was the right word. We were caught flat-footed during COVID-19. But countries were unprepared, but we have hope. There are improvements which were made, which we were all forced to make, and which are beneficial to the patients. And by practicing the advice, lessons learned from these discussions, I believe that we'll be able to improve patient experience for the better. So my name is Francine Mutesi. I'm Division Manager of Medical Technology at RBC. Allow me to thank Dr. Maulana, who joined us here physically. If you can help me thank her. And we thank also Mrs. Natasha Mwenda from Malawi, who joined us online. But before we end, we would like to thank Rwanda Global Healthcare Conference organizers who allowed us to have this session, to have this platform. I hope that we all here have something to take home, whether in improvement of patient care in hospitals, but also in our communities to improve our safety and wash practices so that we do not need to go to the hospitals. We can prevent getting sick already from the communities. So thank you so much. And thank you for participating. Have a good afternoon and enjoy Kigali for those who came from abroad. Thank you.